Hi, welcome today to Aspire class number 4, Study Procedures, Data Elements, Sources, Uses, and Issues. My name is Thomas Delate. I'm a clinical pharmacy research scientist here at Kaiser Permanente, Colorado, and I want to thank you today for watching our talk. The objectives today are to understand the basics of what a study procedure has in it. We'll go through some data elements, identify the sources for getting your data, different kind of data that you could use in a study. We're going to characterize methods for identifying study patients, the subjects that you use, some of the exposures you might be looking at, and definitely the outcomes you're looking for. We'll appraise data limitations and means to overcome these limitations. And finally, we're going to look for factors that you're going to need to calculate a sample size. So the basic contents of a study procedures are your objectives, and then generally we try to apply the hypothesis underneath them to let the reviewers understand what we're trying to do and why we're basing our study on. We'll include a study design, retrospective cohort study design, case control, randomized control trial, etc. We'll describe the inclusion and exclusion criteria that will be used to include the patients or subjects in your study. You'll have a sample size estimation to show that you have enough patients or subjects in there to have sufficient power to detect any differences that may be between your groups. Then you'll talk about the data collection and the sources of your data, where you're going to get these data from, how they're going to be captured, and finally the analytics, maybe it's statistics, maybe it's descriptive. So generally when I think of study procedures, it's a how-to conduct your study, more or less a cookbook. You can be very specific in your cookbook, clear about what you're doing. Therefore, if you're the principal investigator and you're going to be supplying this to programmers and analysts or other investigators at another site, you're pretty specific about what's going to be happening in here. There's not a lot of questions that later come back and wondering what's going on. At a minimum, you can describe the patients you want to identify, who's going to identify them, what data sources they're going to need, and if you're going to be recruiting, where they're going to be recruited, how, and by whom. And then finally, the data that you're going to be collecting and how to analyze these data. So for data, you're going to need information with these data, you're going to need information on sample size. You will need data for sample size, power estimations, identification of your patient, so where you're going to apply the inclusion exclusion criteria. So you'll need data, say you're going to say it's age and sex based inclusion criteria. You're going to have information on that. And then you can use these later for recruitment. So you're going to identify, say, specific clinics that have these patients in there that you're looking for. Later, when you have your data, you'll be doing group assignments. So say it's a retrospective study, how you're going to assign your patients to a intervention or an observation group or a control group. That'll be your independent variable. And then other exposure measurements, perhaps describers of your patients, socioeconomic status, things like that. And then also you're going to be looking for potential confounders. You'll have to have data to measure those exposures. And finally, you're going to have your outcome measurement. This will be your dependent variable, and that'll be the data that you're going to perform your statistical testing on. So there's two main types of data, primary data collection and then secondary. First, we're going to talk about primary data, and that's data that's collected specifically for research purposes. They'll include things like surveys. Maybe you're going to survey patients and or their caregivers, develop a questionnaire, have a questionnaire that you will be providing them. Maybe it'll be a healthcare provider, physician groups. Maybe it'll be the payers. Maybe it'll be the insurance company that you're going to collect information on. And this is data that's specific for research purposes. It's not going to be used for much of anything else. Another way to get it is through key informants, and these could be through diaries. You ask someone to collect information and write it down in their own diary. Maybe you'll use a focus group situation where you'll have a group of participants sitting around discussing different information. And finally, it could be an interview where you actually go out and interview individuals and ask them specific qualitative questions. The other type is secondary data collection. This is collected for non-research purposes. So it could be information in the medical charts that a provider fills out. It could be database information, say labs. And then there's billings and claims databases. So information from hospitalizations, ED visits, where the facility sends a bill to the insurance company, and with that information, then you can use to identify diagnoses of the patients. Another is registries. There's things, cancer registries, reportable disease registries such as infectious diseases. And finally, there's government databases. So the government collects a lot of information. They do their own surveying. And with this information, they will allow you to use that information to do your research studies. So with primary data, as I said, you can assess qualitative data. So that would be, say, you were doing personal interviews with patients and you're asking specific probing questions. You could get quantitative information with your primary capture. You could be asking caregivers to record the times a patient has to measure the researcher controls how and what data are collected in that situation where they're asking patients to record something at a specific time in their caregiver. However, primary data collection is very expensive and it's time consuming. Patients or whomever has to go out there and collect that. You're doing a survey, you have to get the survey ready and mail it out there and then collect that information and record it again. There is potential for incomplete biased information, especially when you're going to the qualitative level or quantitative, we're asking patients or their caregivers to record information. They may forget to write it down, or they may be predisposed to thinking something occurred when it really didn't happen. Secondary data generally is broader data than someone as a researcher can collect on their own, and that's because you're collecting from large databases that have multiple information in there available. Contains longitudinal information. By that I mean that it's data that's recorded over time. You could have information on a patient if they're still within a clinic for years on end, and you still have that information. You're not just collecting at one time point. However, it usually requires training, specialized equipment, specialized computer software to be able to access these data. So here we're going to give an example of some data needs for a prospective study. So this study is we're going to be looking at if endogenous 25-hydroxyvitamin D and 1,25-dihydroxyvitamin D levels are associated with all-cause and cardiovascular mortality. So it's a pretty busy slide. I'll walk you through it a little bit. On the left is the data that we're going to be looking for in the pre-period, looking for these different exposures, demographics, and then potential confounders, as I described before. Then in the middle is how we're going to identify the patients who are going to be in our group. We have our inclusion criteria. One of the important ones is that the vitamin D levels were drawn, so you have that information to be able to divide these patients into lower and upper vitamin D quartiles, as you see in the group assignment. And then during follow-up, you're going to go on out to collect data on the study outcomes. In this case, our outcomes will be all-cause mortality and cardiovascular mortality. So, focusing on the patient identification, the inclusion criteria, we'll need information on their age. Generally, that's a patient's date of birth, probably comes from multiple sources. You could get that in perhaps their medical record. Undergoing coronary angiography, probably going to get that from claims data or through medical chart review. Vitamin D level, looking through your lab database. Chart review may have that information. Membership information generally could be in the chart, but generally you're going to have to look through specific health plan information to identify that. And then especially with membership information, you'll need to identify if the patient had a prescription drug benefit. You would probably want to have information on their drug benefit because you want to know if they're taking other medications and if that information is being captured in their system. So for identifying potential study patients, say we're going to use primary data to collect this information. We could get it from providers' recommendations. So we recruit clinics, and then within the clinics, we ask the providers if they know of a patient that's recently undergoing coronary angiography. Have they had this labs drawn? Then we could ask those providers to refer them to the recruiter and then the recruiter can reach out to the patient. Another way would be for the recruiter to be embedded within the clinic, and that recruiter is reviewing charts, identifying these patients, and so then when the patients come in, they could ask them if they're interested in the study, and or they could outreach them through telephone, email, or a letter to ask them, recruit them for the study. Secondary data is a little different because you're not going in there and waiting around for patients or searching them. There you're looking through very large data sets usually. Now, you could start with a random or targeted chart review looking for these patients, whereas you're understanding that these patients are in a cardiology clinic and that quite a few may be undergoing coronary angiography. So you went in there and randomly picked patients to identify or pick charts to see if the patients were meeting your criteria. But mostly we do a lot of e-screening where you're looking through administrative data. As I said, you would look for procedures, for claims, for angiography. You might look in a registry if they have a registry for patients who received angiographies. When we look through our claims, we're looking through diagnosis codes, your ICD-9 codes, your ICD-10 codes, CPT codes, current procedural terminology that will tell you about the procedure the patient had, and then also DRGs, diagnosis-related grouping. These codes allow you to see during hospitalizations specifically, not specifically, but in general, if the patient had a coronary procedure, and then you could identify those patients, look a little closer and see what's going on. As I said, the age, drug, benefit information usually comes from your membership databases that the insurance company will hold or the health plan. And then vitamin D measurements would be coming from a laboratory. You could also get that from primary data during a chart review, but generally it's been collected already and you're just looking through information that's been stored. Usually you link all these together through a patient identifier, medical record number, some other identifier, and that allows you to link patients through the databases. So here's an illustration of what it looked like to using electronic data, secondary data. There's a programmer and an analyst sitting at their computer screen with all these different abilities to access all these different databases. They have this sophisticated software that would be needed to extract data from them. So typically there's a pharmacy database where information from outpatient dispensing stored. These electronic medical record where providers are coding different information about the patient, including diagnosis and or notes about the patient that they observed. Claims data, as I said, is bills, so they're receiving them from an outside source that the insurance company would pay them or not, and then you could extract those claims for the information that on procedures and diagnosis in the claims. And lastly would be a registry. That would generally be an internal organizational from the insurance company's information that they're storing it. Perhaps it could be also a state registry of reportable diseases as cancer or some infectious diseases. So going back to the data needs in our study here, you'll see that the next phase would be the group assignment. We've identified the patients. We found the patients who had the vitamin D. And then we determine what our upper and lower quartiles are. We assign the patient that, not physically assign them, but assign them through a backside on the computer side of it. And then we follow them up over time. We wait for our outcomes to occur. So we get the group assignment. If we're going to collect this prospectively, we're going to collect it directly. We'd ask the patients to show up in the phlebotomy into the lab and have phlebotomy where they're going to collect the information on their vitamin D levels. We also may see that the provider get a notification of laboratory levels. So maybe it's through a fax or an email, and from that information we could glean what the patient's vitamin D levels were. Secondary data we could use would be chart review. We could actually look through these, or we could, as I was showing before, we could query the electronic laboratory information on this. In this we would use the LOINC numbers for the labs. That's logical observation identifier names and codes, long words, and that's generally not specific enough because that covers multiple labs with one LOINC code. So within that you would go to a CPT, current procedural terminology code, or maybe even internal laboratory codes where the health system has its own codes for each one of these labs that we'd be using. And then we could determine our quartiles of vitamin D levels. We could either use against a standardized vitamin D levels, or we could use it amongst the group of patients we have and just develop our own quartiles. So you also want to use some of the pre-period exposures too, again, to describe your patient population, demographics around sex, um, maybe where they're located geographically. And then we also want to look for potential confounders because this is not a randomized study. In this case, we're just assigning patients based on the observational data of what their vitamin D levels were. So there might other be confounders that may be affecting all-cause mortality and cardiovascular mortality, such as smoking, previous exposure, previous cardiovascular disease. So what exposures are critical? Again, we're looking for potential confounders. We could ask the patients about them if they previously smoked. Maybe the provider kept information on that. We could ask the patient's caregiver on that information. If we're using secondary data, we're looking for previous cardiovascular disease. We can look for diagnoses, maybe medications, statin use. Are they on other sorts of antihypertensives? We may be looking for socio-demographic information. What's their education level? What's their income level? These information can come out of queries of the electronic data. Again, for the diagnosis, we could use the ICD-9, ICD-10 codes. For procedures, we use the current CPT codes, or maybe looking for DRG. Another codes we can use is looking for medication, inpatient medication dispensings, in-office medication dispensings, and that's the Healthcare Common Procedure Coding System, HCPC codes, also sometimes known as J codes because they begin with a J, and generally we think of J as injection. Maybe a patient's receiving an injection of an anti-inflammatory or something like that. And then again, for geocoded census data, we could do that for socio-demographic information. Finally, we're looking for our outcome, all-cause mortality, cardiovascular mortality. How do we get to that information? Well, maybe we could ask again the caregivers if the person they're caring for has deceased. We could look for the provider. Provider would maybe receive information on that, and we could ask them, did they get it? Another way to look through it is membership information from your health plan. For secondary data, we could look for membership information. Now remember, we have to look for, since cardiovascular mortality is one of the outcomes, we're going to have to look for cause of death information. So we're going to have to identify what causes they are. Generally, a cause of death is recorded as an ICD-10 code. We'll have to be able to look through those and determine which are cardiovascular related. There's other mortality data sets. Usually Social Security has different information. The state health department is deaths are reportable incidents, so the state health department has information on death. And then there's finally a deathrecord.com, which is a nationwide gathering service that collects information from all city health departments all over the country and records this. You pay for it, but then that would have information on your patients who left your membership, and you're still trying to follow them to see if they died at a later time. So we collected all this data. And some of these data are still limited by different things. Maybe we didn't collect the right data. Maybe we collected incorrect data that we misclassified patients on. Say we got the labs and we misread the labs, or the labs were actually wrong. They had a decimal point off or something. So we can misclassify patients on that aspect. But for data that's collected without a randomized control trial, we really have to be careful with confounding and bias. And these are systematic errors in design, conduct, or analysis of a study. Usually we concern ourselves both with differential bias, where it affects only one group. Systemic is not as bad, but still bad in the sense that it affects all groups and that the study findings may be incorrect because we didn't measure things the right way. Methodologies are available to adjust control for some of these impact on the study's findings, and let's go through what they are. So one of the big limitations is selection bias, and this can occur as in with our prospective study we just went through, non-randomized assignment to groups. So in this case, the selection is being driven by looking at patients who received a service or received a drug and didn't. Maybe there was some sort of underlying bias that drove a patient to get one thing or the other. It could be something as provider's choice. It could be the patient's choice, something along those. Example would be sicker, healthier patients more likely to receive a medication. So we're testing one medication against another in our study, and we're saying, oh yeah, well these patients got it, these one didn't. Well, there was probably could have been a systematic reason why they didn't get it. One way to get around the selection bias is patient matching. Propensity scores are pretty common now and pretty popular used. And what propensity score is usually based on the likelihood of receiving the medication. So in that case, we would model these patients with logistic regression, and we would include factors that we think would be related towards clinical factors, maybe sociodemographic factors that would be related to the patient receiving a medication or not. Then we would use this propensity score. We can match on it. We can do other things statistically to use that to help us to overcome some of these biases. Matching is a good way to get it. You can do it on the propensity score, but generally you want to do it with other factors involved there too that were not included in your propensity score development. Measurement biases. This is when the outcome exposure variable are measured inaccurately, reported inaccurately. Say a patient's keeping their own diary and they missed a couple of days of something, or they inadvertently recorded it incorrectly. Some of the exposures they received or maybe one of the outcomes. Another concern is when we're using diagnosis codes and we're looking for an outcome, but the diagnosis codes are used a little too much and they're not really accurate for patients who truly had the event. Sort of one example would be bleeding. A lot of patients get coded for a bleed and they don't really have one. Another problem would be we're using questions in a survey and they're not validated, so the patients or whoever's receiving the survey doesn't really understand the questions you're being asked. Sometimes we're concerned about our sources. Big concern would be infusion data. We're thinking patients received an infusion based on a code, an ICD-9 code or a procedure code, when in fact they were ordered, but the patient never received that information. When you misclassify a patient on an outcome, say we got codes back from the hospital and we misinterpreted the code for the 25 versus the 125 vitamin Ds, and we put those in the wrong set, and then we misclassified the patients based on that. Really, one best way to overcome this measurement bias is to understand the codes, understand how well codes are working, understand your data sources if they're validated, and make sure you have very good sources of information. This can be written into your procedures. There's potential for validating these codes. Maybe you do a chart review when you see someone has an outcome that you're interested in. You want to go back in there and chart review it and make sure that that code really represented what the patient had. Another big problem we have with our non-randomized study is confounding. This occurs when extraneous variables, they correlate with both the dependent variable and the independent variable, and they basically mess up the relationship between them when we're estimating the exposure's effect on the risk of disease. We can address confounding by a couple of ways. Specification. In that case, we just exclude the patients that have a confounder. Say we're looking at cardiovascular disease and we just don't want to have smokers in there because we know it's related to maybe the exposure would be, did the patient receive an intervention of some sort, and the outcome would be death. We know smoking is related to both. We can just exclude smokers from there. Another way around it would be matching. We can match on the confounding factor. That takes some little bit of sophisticated software to do that. You don't want to do it by hand. You would run it through so it's truly random, but there in this case you would match patients who have an exposure of smoking to other patients who have an exposure of smoking. With our multivariate regression analysis, it allows us to adjust for the effect of the confounding factors. You could even do it after they're matched. You can still adjust for other factors too, because generally with matching you can only match on a few factors. You can't match on too many. Then you lose too many patients who do not match. So you want to keep your matching limited. Finally, stratification. Say we wanted to keep our smokers in the study. We didn't match, but we wanted to stratify out. So we wanted to take smokers and take them out, include them in the study, but separate them and do sub-analysis based on those who do not exhibit the confounding factor. So you would take smokers out and look at smokers alone in the analysis. So Last but not least, we're getting into sample size and power. So when you're doing your procedures, your sample size is the number of patients you need to detect a significant difference if one exists. So you really need to test these out front to see how many patients you're going to have. Power is a probability to detect a statistical significant difference between groups with the sample size available. So generally we set our power at 80%. And we say we're pretty confident if we have 80% power, which means 8 times out of 10, if with this sample size and the effect is real, we would detect a statistically significant difference. A lot of ways to do this. There's different statistical packages to use. One of the reasons we really want to do it is to be ethical about this. We don't want to put patients or their data at risk if we don't need that many patients. Conversely, we have to have enough patients. Otherwise, we did this and we didn't be able to detect a difference. So we use patients' data without really knowing what we could find with it. If you're doing enrolling patients, it can be costly to have too many patients enrolled. So you want to make sure you just have a minimum amount you'll need so you don't spend all that money on recruitment. One of the first things you have to do for your sample size is determine the response variable you're going to have. There's 3 categories: dichotomous, yes or no, did it occur, did they survive or die. We're looking for those. We'll look at event rates or percentage of patients who had and didn't have the outcome. Another would be continuous outcomes: blood pressure, money, cholesterol levels. So in this case, you're looking at means or medians and compare those between the group. The last would be time to failure, for example, time to death. We use a hazard ratio there, and we'll determine intervention and control groups. So there's different ways to determine sample sizes for all these different outcomes. Another one we consider sometimes is non-inferiority or other measures of equivalence. They take a little bit different way to approach sample size. Again, software is available to do this. In those cases, you're going to have to set parameters within ranges that you feel that are non-inferior or equivalent, and then use that in your sample size calculation. So the key concepts are hypothesis testing. So you're going to base it on the hypothesis. You're going to say, well, there's no difference between the groups. We also want to know if it's to be true. If your goal is to accept or reject the null, sometimes you will have no differences. You'll accept the null hypothesis. If there is differences between the group, then you reject the null and you'll accept the alternative hypothesis. Generally, when we write our procedures, we don't get into the null and the alternative. We just state the alternative, meaning we believe that these 2 groups will be different on this value. We don't go into the null, which is we don't think there's any difference between the 2. So for your sample size estimation, you're going to use these factors. Alpha, and alpha is typically thinking of your p-value. You want 0.05, that's your alpha, so you want to have that. That's typically what it's set at, but you could set it at a higher level. Say you're concerned about multiple testing your data, you could set it at 0.25. You could set it to 0.1, but that's generally not considered standard with statistics. Beta is your power, again, which we described before. If you have a beta of 0.2, that says that 2 times out of 10, we would expect this with this sample size that we wouldn't be able to detect the statistical significance. The opposite of that is 80% of the time with this, we will be able to detect the statistical significance. And then the expected difference is usually what we think of the effect size, proportional and mean. So we say between these 2 groups, we expect a mean difference of, say, 0.3, a mean difference of 3 millimeters of mercury for blood pressure, or maybe a proportional difference. We expect one group to have an event rate of 20% and the other group to have an event rate of 15%. And with those, then we can start building our sample size. We also need a standard deviation if we're using means for continuous outcomes. So here's some online calculators for you to try. I recommend going in there and playing around with them. They're pretty easy to use. You'll have to look for different ones based on the type of outcome you're looking for versus the dichotomous versus your continuous versus your time to event analysis. Thank you for your time with this. Appreciate you paying in there.